All right, let's get right into this explainer. We're tackling a massive, everyday clinical decision in neonatal care today. Now, if you work in pediatrics or the NICU, you already know this topic inside and out. But nailing down the exact, evidence-based protocols, that is absolutely crucial for your patient's long-term outcomes.
Because, let's face it, this is the ultimate question every single pediatrician and NICU nurse faces right at discharge. When exactly should you stop preterm formula? Look, it is definitely not a guessing game, and a one-size-fits-all approach, yeah, that simply doesn't work here.
So here is our golden rule. We must always individualize our timelines based on corrected age and catch-up growth. Never just rely on chronological age. That is the foundational concept we're going to build everything on today.
Okay, moving right into Section 1, Preterm Formulas Baseline Timelines.
40. That is the magic number we're starting with. 40 weeks post-menstrual age.
This right here is your absolute minimum baseline. You need to keep administering that nutrient-enriched preterm formula until the infant hits term-corrected age. So, at a bare minimum, you're looking at 40 weeks post-menstrual age.
But, what about our more vulnerable infants? Well, that brings us to our next big number, 3. 3 months corrected age.
If the infant is very preterm, meaning they were born at less than 32 weeks, or if they have a very low birth weight of under 1,500 grams, we absolutely have to push that minimum out. A lot of these babies benefit immensely from keeping up with their nutrient-enriched formula until at least 3 months corrected age.
All right, Section 2, Post-Discharge Formulas, Clinical Guidelines.
So who actually needs this after they go home? Well, these are the specific criteria for when you need to write a script for those enriched post-discharge formulas. Basically, you're looking for infants with a birth weight of less than 1,800 to 2,000 grams, babies showing poor catch-up growth, or honestly, anyone with ongoing nutritional concerns.
And the timeline really shifts depending on their growth percentiles. Generally, 3 to 6 months corrected age is your standard target for adequate catch-up. But if you've got a very preterm infant with incomplete catch-up, you want to aim for that 6-month mark. And for suboptimal growth that needs specialist supervision, you might even need to extend that window up to 9 to 12 months.
Let's move to Section 3, Breastfed Infants, Natural Feeding.
Obviously, mother's own milk is preferred whenever possible. And while human milk fortifier is pretty standard protocol while the baby is still in the hospital, it's typically stopped right around the time of discharge. But keep in mind, some of your high-risk infants might still require additional nutritional supplementation even after they leave your unit.
So how do we actually track our success once they're home? That's Section 4, Monitoring Growth, Catch-up Metrics.
You need to bring them back every 2 to 4 weeks post-discharge to rigorously monitor 4 distinct metrics. We're talking weight gain, length, head circumference, and feeding tolerance. It's like a giant puzzle. You have to evaluate all of these pieces together to really see the full clinical picture. And here is your primary benchmark for success. You are targeting roughly 20 to 30 grams of weight gain per day in early infancy. Lock that number in.
Wrapping things up with Section 5, Clinical Summary, Practical Guidelines.
So the clinical pathway dramatically splits based on gestational age at birth, right? We're looking at late preterm, meaning infants born between 34 and 36 weeks, versus our very preterm infants, born at less than 32 weeks.
For your late preterm infants who are growing well, the pathway is actually really straightforward. You can usually safely transition them over to a standard formula right around their term date, or just shortly after they are discharged. But for your very preterm or very low birth weight babies, you must hold the line with the enriched formula. You have to continue that nutrient-enriched support until at least 3 months corrected age, and you stretch it right up to 6 months corrected age if their catch-up growth is still incomplete. Before you make any changes, you should run through this exact 3-point checklist. You only switch to standard formula when 1. Catch-up growth is completely satisfactory. 2. Their growth is tracking an appropriate percentile trajectory. And 3. There are absolutely 0 ongoing nutritional concerns. And look, this isn't just theory. This protocol is strictly aligned with the highest standards from ESPGAN and the American Academy of Pediatrics. Both organizations emphasize exactly what we started with today: individualization based on corrected age and actual growth, not just chronological age.